Welcome to the latest installment of the AST Journal Club series. Today's Journal Club features the article, The Best Insulin Delivery is a Human Pancreas. The session is hosted by AST's Kidney Pancreas Community of Practice. In a moment, I will turn the session over to our moderator, Dr. Jonathan Fridell from Indiana University School of Medicine. But before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This Journal Club is being recorded, and the archive will be available on the MyAST website in 2 to 3 business days. Please note, all of your lines have been muted so that only the presenters and panelists can be heard clearly for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate using the Q&A button in the Zoom webinar panel. Questions submitted via chat may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline or post the full question with the answer on the website following the Journal Club. Finally, when you log off at the conclusion of today's session, you will see a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to Dr. Fridell to begin.
Thank you all for joining us today for this AST KPCOP Journal Club. I'm Jonathan Fridell. I'm Chief of Abdominal Transplant Surgery at Indiana University and the Director of Pancreas Transplantation. The study for discussion today is The Best Insulin Delivery is a Human Pancreas. This was a manuscript published in Clinical Transplantation this past year. For context, we're currently living in a world where there's competing therapies, including insulin injected pumps, CGMs, closed loop. There's pancreas transplantation, islet transplantation, and all of these different therapies are believed to provide equivalent and adequate okay glycemic control. Pancreas transplant for specific indications is the standard of practice, and when successful, provids euglycemia. It's better than okay, but it's frequently grouped in with the others, with the standard usually being a hemoglobin A1C of less than 7. It's difficult to directly compare modalities because we're very unlikely as a pancreas transplant community to be willing to randomize candidates for transplant into standard insulin pump, closed circuit, or whatever, versus pancreas transplantation when indicated. So this study was a very creative solution to this problem, with subjects receiving both therapies in sequence. I strongly feel that this was one of the most creative and impactful papers of the last few years that really saw address this particular issue, and that's why it was recommended for Journal Club. I would like to acknowledge Casey McCune as the first author. She's recently departed the institute where the study was performed, but I would like to recognize her contributions to this very important study. Our presenting author is Dr. Dube. He's a native of New York City. He received his MD from Columbia University. He completed his internal medicine residency at Beth Israel Deaconess Medical Center in Boston before returning to New York to complete fellowships in general nephrology and then transplant nephrology. After completing his training, he joined the faculty at Columbia University, where he is now an associate professor of medicine, and he is also the medical director of pancreas transplant. With him, hopefully joining us, will be Dr. Lloyd Ratner, who is very familiar to this entire community, one of the founders of laparoscopic donor nephrectomy, very open, loud advocate of transplant, pancreas transplantation, former ASTS president, and very active member of UNO's board. I will start with, go ahead, Dr. Dube, you're already sharing your slides. The microphone is yours.
Okay, thank you, Dr. Fridell, for that introduction. And I'd like to thank the AST Kidney Pancreas Community of Practice for inviting us to present our study today. As Dr. Fridell mentioned, the lead on this study was Dr. Casey McCune, who was a kidney and pancreas transplant surgeon here at Columbia when she did this work. She's now an associate professor of surgery at Mount Sinai Hospital across town. And also Dr. Nina Owen-Simon, who is one of our general surgery residents here at Columbia and is going into transplant. These are the conflict of interest for myself, Dr. Ratner, and our moderator, Dr. Fridell. I won't be discussing off-label use. I was thinking recently of the opening line from A Tale of Two Cities. It was the best of times, it was the worst of times. And, in some ways I thought it was applicable to our field, because the last 30 years or so have seen remarkable progress within the field of pancreas transplantation. Our results keep getting better. These figures are from the most recent report from the International Pancreas Transplant Registry covering all pancreas transplants performed in the US from 1966 through 2020. The panel on the left is patient survival for SPK recipients. The panel on the right is patient survival for recipients of solitary pancreas transplants. Each line represents a subsequent 5-year interval. And essentially what you can see is for both SPKs and solitary pancreas transplants, in each succeeding era, the outcomes have gotten better and better and better. And so we're now at the point where we're seeing, 1-year patient survival after SPK of 97%, 98% with PTA, 96% with PAK, despite the fact that these patients, were uremic and were chronically immunosuppressed prior to the transplant. But it's not just that our patients are living longer, they're living longer with functional pancreas transplants. And again, these are data from the International Pancreas Transplant Registry. The panel A is pancreas allograft survival in SPK recipients. Panel B is the kidney allograft survival in SPK recipients. Panel C on the lower left is the pancreas survival in the PAK recipients. And then panel D is pancreas survival among PTA recipients. And again, each line representing subsequent 5-year eras. And you can see that there's been remarkable progress over the long term. And so we're now seeing, 1-year pancreas survival greater than 90% for SPK recipients and greater than 86% for recipients of both PAKs and PTAs. So it's not just that our patients are living longer, they're living longer with functional allografts. And you can see a dramatic improvement in the median survival or half-life of pancreas allografts over the past 3 decades. From the early era, 1986 to 1990, for example, the SPK pancreas half-life was only 73 months. In the more recent era, half-life is 134 months. So that's an improvement of 5 years of half-life. For the PAK recipients, the half-life improvement was pretty similar, about 5.5-year change over 3 decades. And for the PTA, it was about a 4.5-year change. If you look at the number in parentheses, that's the conditional half-life. So that's all patients who are alive with a functioning pancreas transplant at 1 year. And functioning transplant here is defined as insulin independence. And you can see that the conditional half-life now for an SPK pancreas is 170 months, which is approaching 15 years without insulin for our patients. And for PAK at 113 months, it's approaching a decade. PTA is at about 9 years. Now, multiple factors have contributed to our dramatic improvement in allograft survival over the past 3 decades. There's been a significant reduction in the rate of early technical failure, which was one of the primary drivers of poorer outcomes in earlier eras. There have been tremendous advances in both induction and maintenance immunosuppression that have led to a significant decrease in the rate of acute rejection and early immunologic graft loss. And then there's been also significant improvement in the management of post-transplant complications, for example, newer antiviral therapies for management of CMV. And we know from data that were published in earlier eras that pancreas transplantation offers improved long-term glycemic control when compared with intensive insulin therapy. And this slide is from about 20 years ago. And so it's looking at data from the pre-insulin pump, pre-CGM era. The 2 top lines represent the data from the DCCT study, which was a randomized controlled trial looking at kind of standard of care insulin therapy versus intensive insulin therapy that was published in the early 1990s. Now, for context, standard of care therapy at that point was multiple daily injections with an aim to target a hemoglobin A1C of around 9%. And you can see that they roughly achieved that over the 5-year study period. The intensive therapy arm in that study was multiple daily injections to try to target a hemoglobin A1C of around 7%. And you can see that they were fairly effective in reaching that goal for the 5 years of the study. And that 2-point difference in A1C was associated with significant reduction in diabetic microvascular complications, for example, retinopathy, de novo albuminuria, and CKD, also reduction in macrovascular complications and improved mortality over the long term. The 2 lines in the middle right here represent data from about 20 years ago looking at islet cell transplantation. And you can see here that with the islet cells, within the first year, patients who were insulin independent got down to an A1C of slightly under 6%. Those who had an islet transplant but remained on insulin were about 1 point higher on their A1C. But those lines then start to converge, and by 2 to 3 years, you can see there's not much of a difference after islet transplant, whether you remained on insulin or remained insulin independent, with an A1C range somewhere in the mid-6s. The dotted line on the lower here represents data from the University of Minnesota that was published in 1996. So that was the pre-tacrolimus, pre-mycophenolate era. And this is just hemoglobin A1C values in their solid organ pancreas transplant recipients over a 5-year period. And what you can see is that they started out poorly controlled with A1Cs at around 8% prior to their transplant. And they got down to A1Cs of 5 or slightly above 5% by the end of the first year after transplant. And they were able to maintain that degree of glycemic control over the next 5 years. So the difference with pancreas transplant and the difference between A1C with pancreas transplant and the intensive arm of the DCCT study was about the same in terms of glycemic control as the difference between the intensive arm and the conventional arm of the DCCT study. And yet, despite this, we all know that there have been improved outcomes, but they have not been associated with increased transplant or pancreas transplant volume in the United States. In fact, the opposite has occurred. There's been a long-term decline in volume. The panel on the left here looks at the annual number of pancreas transplants performed in the United States from 1966 to 2021. And you can see that starting in the kind of mid 80s going into the 90s and early 2000s, there was a dramatic increase in the total volume of pancreas transplants within the US, reaching a peak of over 1,400 transplants per year in the early 2000s. And then there started to be a steady decline. And you can see that decline was slow but steady. And I'm going to switch here in the early 2010s to the panel on the right here. This is a figure from the most recent annual data report on pancreas transplant from the SRTR, which is looking at total pancreas transplants performed in the United States by transplant type over the past decade. The green line represents PAK and the brown line represents PTA. And you can see that the transplant volume in the US over the last decade for those two types of pancreas transplants has declined by about 50%, continuing the long-term decline that started in the early 2000s. There's a slightly different trend in the SPK group. Transplant volume did continue to decline from 2010 to about 2014, which was when the pancreas allocation system was implemented. And from 2014 over the next 5 years, you can see that there was a slight increase in the overall volume of pancreas transplants in the US, reaching over 800 again for the first time in about a decade, shortly before the onset of COVID. And in the last 2 years, in the setting of COVID, there's been a slight decline. So, what's going on? Why is there such a disconnect between the success and the advances that we've had in our field and the reality that we're seeing? And there have been a lot of publications that have been put forth in the last few years trying to dissect why there has been such a decline in pancreas transplant volume in the United States. And these are just some of the titles that I plucked from PubMed. There have been a lot of potential reasons for decline in pancreas transplantation that have been suggested. Some of them relate to factors related to donor selection, for example. Some of them relate to the training where you have decreased volume leading to decreased comfort level doing the surgery, and so it's kind of a downward spiral. But I think one of the big things is that we just may not have done a great job publicizing our success. So the improved long-term outcomes after pancreas transplant I don't think are as well recognized outside of the pancreas transplant community as we'd like them to be. And we have a lack of a primary referral source for our patients. Our patients are referred almost always for kidney transplant evaluation. A lot of them haven't heard of pancreas transplant. Oftentimes their referring providers haven't necessarily thought of or heard of pancreas transplant. And so patients have this reference bias where they say, like, I'm referred for kidney transplant. And even when you introduce pancreas transplant and the idea of a kidney pancreas transplant or a PAK, they may not be as willing to go forth with that. And patients who may be appropriate pancreas transplant candidates are often referred to centers that don't have pancreas transplant programs. And so pancreas transplant may not even be considered as a potential treatment option for them. And one of the things that we talk about in our paper is there's also been a lot of improvement in diabetes management over the last 30 years. In many ways, it's been the best of times for the endocrinology field as well. There are better insulin analogs, the continuous glucose monitors, insulin pumps, SGLT2 inhibitors, GLP-1 agonists, and all of these have led to the impression that there is significant improvement in glycemic control in diabetes patients as a result of these innovations in management. And that has, I think, in part diverted interest away from pancreas transplantation. And so I think, as a pancreas transplant community, we need to ask ourselves, how does pancreas transplantation compare with the newest insulin technologies? And to do that, I think it's helpful to review some of what we know about the glycemic control that insulin technologies can actually provide. So these are data, pictures from the IDCL study. This was a randomized controlled trial looking at a closed loop system versus a control group of patients who were maintained on a sensor augmented pump. This was published about 4 years ago now. The primary endpoint was time in range, which is typically considered a glucose between 70 and 180, which is a fairly broad range. This was a 26-week study, and you can see here that there was a significant improvement in time in range with the intervention group using a closed loop system. The time in range increased from 61% to 71% of the day, whereas it remained unchanged 59% in the control group. And you can see here, this is looking at diurnal variation. It's interesting that you see some improvement within the closed loop system early on, overnight in the morning, and after patients wake up and maybe eat breakfast. And then towards the end of the day, into the afternoon and early evening, there wasn't that much of a difference, but still a 10 percentage point improvement in time in range. And what that translated to in this 26-week study, so 6 months, is that the baseline hemoglobin A1C with the intervention decreased from 7.4% to 7.1%. And importantly, the time spent in hypoglycemia, defined as a glucose level less than 70, did decrease as well from 3.6% to 1.6%. And so the most recent standards of medical care for diabetes, published by the American Diabetes Association, has the following recommendations for glycemic targets. So they recommend an A1C goal for many non-pregnant adults of less than 7% without significant hypoglycemia. And what we can see here is that even using insulin pumps in randomized controlled trials, which is a very select group of patients, actually the mean hemoglobin A1C was above the target that the ADA recommends. And there's probably only about 20% of patients in the country who are kind of meeting those goals consistently. And then for patients who are using continuous glucose monitoring, they recommend a parallel goal for many non-pregnant adults having time in range greater than 70% with time below range less than 4%. And so in this study, at least with the intervention group, they were able to kind of just meet those goals in terms of the time in range and the time in hypoglycemia. Unfortunately, there aren't really any good comparison trials head-to-head, and there probably won't be, as Dr. Fridell mentioned, looking at randomized controlled trials of pancreas transplantation versus other diabetes therapies. That said, we do have a small study from the Mayo Clinic where they showed that pancreas transplantation, at least in the short term after transplant, provides more time in range and fewer hypoglycemic episodes. So they had 26 pancreas transplant recipients, 11 SPK recipients, 9 PAK recipients, and 6 recipients of a pancreas transplant alone, who underwent continuous glucose monitoring for a mean of 5.6 days towards the end of their first month after transplant. All of the patients were being maintained on triple drug immunosuppression with tacrolimus, mycophenolate, and prednisone, and importantly, a mean daily prednisone dose of 12 milligrams per day. So not insignificant and could potentially contribute to some hyperglycemia. And what you can see is that the time in range for this group was 91%, again, defined as a glucose between 70 and 180, with very minimal time spent in hypoglycemia, less than 70 at 0.7%. Now, they used a control group in this study of patients with type 1 diabetes who were maintained on insulin pumps and managed in the insulin pump clinic at the Mayo Clinic. They were all in good health, so they did not have advanced CKD. They did not have kidney transplants on immunosuppression. And you can see here that this real-world data for their well-controlled type 1 patients with type 1 diabetes, their time in range was 62% compared to 91% after pancreas transplant. So that's a difference of 29%, which kind of corresponds to about an additional 6 hours per day with time spent in range for patients who have a functioning pancreas transplant. And if you look at the hypoglycemia in the patients on the insulin pump, it was 6.1% of the time compared to 0.7% with patients after pancreas transplants. That difference of 5.4% reflects more than an hour a day that patients with pancreas transplant are not experiencing hypoglycemia compared to the well-controlled patients on insulin pumps. And we know that the outcomes seen in randomized controlled trials, the outcomes seen in the real world, may not always apply to patients who are pancreas transplant candidates or pancreas transplant recipients. They are different from patients in randomized controlled trials in terms of their comorbidities, and often different from the patients who are managed in insulin pump clinics. They have progressive diabetic complications, most commonly nephropathy, but for our patients who are candidates or recipients of PTAs, often advanced neuropathy, despite management by endocrinologists. And they often have advanced CKD and end-stage kidney disease, and there's very little data looking at efficacy of insulin pump therapy in patients with advanced CKD or end-stage kidney disease. And unfortunately, we have no data comparing the effectiveness of current advanced insulin management strategies to the long-term glycemic control that's provided following pancreas transplantation. And so that's what our study here attempted to address. So this was a single center retrospective analysis of all of our pancreas transplant recipients here at Columbia University from the beginning of 2008, which was the inception of our program, through August 31st, 2021. For our analysis, we included all subtypes of pancreas transplants. So we included SPK recipients, PAK recipients, and PTA recipients. And our primary aim was examining glycemic control with the most current insulin delivery technology. So for patients who were managed with an insulin pump and CGM prior to transplantation versus the glycemic control following pancreas transplantation. So essentially patients were crossing over from one diabetes therapy to another diabetes therapy. This is our immunosuppression protocol that we use here at Columbia. We use anti-thymocyte globulin for induction. We give a fairly high dose, 10.5 milligrams per kilogram divided over 7 days. We are an early steroid withdrawal center. Patients receive methylprednisolone 500 milligrams intraoperatively, and then it's tapered off rapidly so that by postoperative day 4, they're no longer receiving steroids. We use dual drug maintenance immunosuppression with mycophenolate, 1,000 milligrams twice a day, and then immediate release tacrolimus, targeting a trough level between 10 and 12 for our first 3 months after transplant, target level 8 to 10 for months 3 to 12 after transplant. And then beyond month 12, the target trough level differs slightly depending on the type of transplant. We do target a slightly lower trough level for our SPK recipients, about 6 to 8, whereas for our PAK and PTA recipients, we target a level between 8 and 10. In terms of definitions used in the study, for type 2 diabetes, we used a fasting C-peptide level above 2.0 nanograms per milliliter. I know there's been some controversy about use of this definition, but we used this because this was what was implemented for the pancreas allocation system in 2014, and it's consistent with definitions that have been used in some of the prior studies looking at outcomes with patients with type 2 diabetes. Our BMI during the period of the pancreas allocation system where the BMI criteria was in effect, our BMI for all patients was obviously below the maximum allowable BMI. Prior to 2014, and then in the last few years after the BMI criteria was lifted from the pancreas allocation system, all of our patients had a BMI below 30. And we use a total daily insulin requirement cutoff of less than 1 unit per kilogram per day in terms of who might be a candidate for pancreas transplantation. Our main outcome of interest was glycemic control as measured by the hemoglobin A1C, and we looked at this at the time of initial transplant evaluation, at the time of transplant, the initial post-transplant reading, which was done between months 3 and 5, and then at 1 year post-transplant. Our outcomes were analyzed in the overall cohort, and then we analyzed them again based on the pre-transplant insulin delivery type, whether they were using a CGM and a pump or whether they were on multiple daily injections with self-monitoring. So this slide shows the recipient demographics. Overall, there were 134 patients in our cohort. 38 of those patients were managed with a pump prior to the transplant. 96 were on self-monitoring and multiple injections of insulin. About 40% of our recipients were female, and the mean age was in the early 40s, and there were no differences between the CGM and the self-monitoring group. Roughly 10% of our patients had type 2 diabetes. More of those patients were represented in the self-monitoring group, although the difference was not statistically significant. In our overall cohort, about 64% of patients received an SPK, 28% received a PAK, and 6% received a PTA. There were 3 transplant recipients here. 2 of them had received previous pancreas transplants that had early graft thrombosis, one after an SPK and one after a PAK. And then there was 1 patient who received a redo PTA. And you can see here there was a slight difference in access to pump therapy among the transplant types. So patients receiving an SPK were slightly less likely to be on a pump than the representation in the overall cohort. And similarly, patients receiving a PTA, although the numbers were small, were slightly more likely to be on a pump compared to self-monitoring. A few additional recipient demographics, which did not make it into the final paper. So in terms of the race and ethnicity, about 50% of our patients were non-Hispanic white, 19% were Black, and 26% were Hispanic. But if you look at the breakdown by access to pump therapy versus the standard self-monitoring and daily injections, there was a significant difference in terms of the trend there. So patients who were on an insulin pump were more likely to be white and less likely to be Black than the overall cohort. The percentage of Hispanics was roughly equal. If you look at the duration of diabetes, these patients had been suffering with diabetes on average for 28.4 years. Patients who were on a pump had a slightly longer duration of diabetes, about 5 years compared to the self-monitoring group, and that was statistically significant. And there was also a significant duration of diabetes in the pump group among the PAK recipients compared to the self-monitoring group, about a 7-year difference. The differences in SPK and PTA recipients were not significant. In terms of access to transplantation, overall 15% of our patients were able to receive a preemptive SPK. And there was a significant difference. So preemptive SPK was much more likely in the pump group, where 37% of patients were able to receive a preemptive SPK, as opposed to in the self-monitoring group, where it was only 9%. And then among the PAK recipients, the time from kidney transplant to PAK, overall, the median was 953 days, so around 2.5 years. And there was no statistical difference between the pump group and the self-monitoring group in terms of time from kidney to PAK. This slide shows the trajectory of the hemoglobin A1C from the time of initial transplant evaluation to 1 year post-transplant. And you can see that the mean A1C at the time of evaluation was 8.5. At the time of initial evaluation, we made sure that all of our patients were being managed by endocrinology. They were either referred to an endocrinologist here at Columbia at our diabetes center, or for those patients who live farther away from the hospital, they were referred and managed by a local endocrinologist prior to transplant. The mean time under management between evaluation and transplant was 16.4 months, so over a year. And yet, despite that, you can see the A1C at the time of transplant was still 8.3. So despite being managed by endocrinology, there was very minimal change, as you can see here in panel B, the decrease of only 0.2. By contrast, the hemoglobin A1C dropped fairly rapidly after transplant and post-transplant. You can see there, it settled out at about 5.1 at the post mark and 5.2 at the 1 year mark. And you can see here that represents a decrease in hemoglobin A1C by over 3 points, and these differences were statistically significant. And this table kind of shows the average change in A1C over time from evaluation to 1 year after transplant for each time interval for both the overall cohort and then the CGM and the self-monitoring groups. For the moment, I'm just going to focus on the overall cohort, which is the panel on the left here. And you can see that from evaluation to the time where they came in transplant, which represents the pre-transplant value on the day of transplant, the decrease in hemoglobin A1C was 0.3, which was not significantly different. From evaluation, though, to that initial A1C that was checked between 3 and 5 months, the difference was dropped by hemoglobin A1C dropped by 3.4, and it was 3.3 from evaluation to 1 year. Both of those differences were highly statistically significant. Similarly, the difference from the initial pre-transplant value on the date of transplant to the first post-transplant value, the A1C dropped by 3.1 points, and it maintained that for the remainder of the first year. And again, those differences are highly significant. And the change from the initial post-transplant value to the end of the first year was only 0.1, and that was not statistically different. This is figure 2, which looks at the trajectory of hemoglobin A1C from the time of evaluation to the 1 year mark after pancreas transplant. So just in the pump and the CGM group, so just those 38 patients who were maintained on pump therapy prior to transplant. In this group, the A1C at the time of initial evaluation was 8.2. And again, all patients were either being managed by an endocrinologist here at Columbia or locally. The mean time under management between the time of initial transplant evaluation and the date of transplant was 15.4 months. And again, that you can see that despite being managed by an endocrinologist with a pump and continuous glucose monitor, the decrease in hemoglobin A1C over that 15-month period was only 0.1 points, a difference not statistically significant. After transplant, you see a similar decline in the A1C, similar to what was seen in the overall cohort, so the hemoglobin A1C. By the time you reach the initial post value was about 5.1, and increased to 5.2. And you can see in panel B just that significant change in hemoglobin A1C from the time of evaluation to the other 3 points. And that's summarized in a tabular form here, back in table 2 again. You can see here the CGM and pump group. From evaluation to transplant, there was no significant difference in the change in hemoglobin A1C of just reduction by 0.1. From the time of evaluation to the initial post value reading, it was a decrease in 3.1, and that was maintained over the rest of the first year, change in A1C of 3.0. And again, those highly significant values. And then from the time of the date of transplant to the initial post-transplant value, the A1C decreased by 3 points, and it maintained that change over time to the end of the first year. Again, highly significant, and the change from the post to the 1 year mark was minimal and not significant. If you look on the far right of the table, then this is the cohort that was maintained on self-monitoring and multiple daily insulin injections. And you can see that from the time of evaluation to the date of transplant, there was a slight decrease in the A1C of 0.3. The difference was not statistically significant. However, from the date of evaluation to the initial post-transplant mark, the A1C declined by 3.5%. And it maintained that to the end of the first year, again, highly significant. And from the date of transplant to the post-mark and 1 year mark, the A1C decreased by 3.2%, highly significant. So both in the CGM pump group and in the self-monitoring group, marked reduction in the hemoglobin A1C from the time of transplant to the end of the first year. This is table 2B. We kind of looked at the subgroup of patients with type 1 diabetes, which was the majority of the cohort. Of the 134 patients, 121 had a diagnosis of type 1 diabetes, and only 13 patients met criteria for the definition of type 2 diabetes used in this study. And you can see here that in the subgroup of patients with type 1 diabetes, the outcomes are fairly similar to the overall cohort. From evaluation to pre-transplant, there was a slight decrease in the A1C that was by 0.3. That was statistically significant. From the time of evaluation to post-transplant, though, the A1C decreased by 3.5%, and it was maintained at 1 year. And then from the time of the initial pre-transplant evaluation to the post-transplant mark, the A1C declined by 3.1%, and from pre to 1 year, it would decrease by 3.1%. And so you can see that in the overall cohort of patients with type 1 diabetes, similar results with a marked reduction in A1C that's maintained afterwards, and compared to relatively poor glycemic control prior to the transplant. If you look at the patients then with type 1 diabetes who were managed on an insulin pump, and this was 37 of the patients pumps. 37 of the 38 patients in our overall cohort were type 1 patients with type 1 diabetes on pumps. You can see here from the time of evaluation to the time of transplant, the A1C changed negligibly. It only decreased by 0.1. That was not statistically significant. Whereas from the evaluation to the post mark and the 1 year mark, the A1C decreased by 3.1% and 3% respectively. And then from the date of transplant to the post and 1 year mark, it decreased by 3% and 2.9% respectively. Those differences were highly significant. So that significant decrease in the A1C between the evaluation and pre-transplant and the overall cohort of patients with type 1 diabetes was really driven by slightly improved control for patients managed in the self-monitoring group, actually, rather than the more novel insulin delivery systems. Their A1C decreased by 0.4 over that 12-month period. From evaluation to post, you can see that the A1C decreased by 3.5% though, and actually maintained at 1 year. And then from the date of transplant to the post and 1 year mark, the A1C had decreased by 3.2. all those changes are highly significant. And from the post to the 1 year mark, there was no change in glycemic control. So significant decrease within the first 3 to 5 months that was maintained for the duration of the first year after transplant. Now, as I said, there were only 13 patients in our overall cohort who met the definition for type 2 diabetes, so we're unable to perform any analysis looking at the CGM and pump subgroup. That said, you see similar trends to the overall cohort in terms of improvement in glycemic control. The A1C at evaluation was 7.9%, 8.4% on the date of transplant, 5.4% at the initial post-transplant reading, and then 5.2% at the 1 year mark. 2 more slides that didn't make it into the final paper, but we looked at the subgroup of patients who received an SPK, and we analyzed them in a similar way by looking at their overall their pre-transplant insulin delivery system. So these patients overall were managed for about 17.1 months between initial evaluation and receiving their SPK. Time under management was 14.3 months for the insulin pump group and 17.9 months for the self-monitoring group. So all these patients, again, under management by an endocrinologist for over a year prior to transplant. The p-values on the slide here represent the comparison between the CGM and the self-monitoring group. But just going down the overall group, you can see a slight improvement in the A1C that was not statistically significant between the evaluation and transplant time, decreased from 8.4 to 8.1. Most of that was driven by improvement in patients in the self-monitoring group, actually, rather than the pump group. Their A1C decreased from 8.6% to 8.2%, although the difference was not statistically significant. In the pump group, there was a negligible change of only 0.1%. And all three, in the overall group and then the 2 subgroups, you see a dramatic improvement in A1C between transplant and the post-mark and the 1 year mark. And all of those changes are highly significant. Now, interestingly, if you compare the pump group to the self-monitoring group, at the initial post-transplant value, those patients who had been managed on a pump had an A1C of 4.7% compared to 5.1% in the self-monitoring group. And that difference was statistically significant. And if you look at values at the 1 year mark, it was 4.9% versus 5.2%, a small number overall in the cohort, but there was a trend towards statistical significance there, suggesting that maybe there were some unmeasured differences between the 2 groups in terms of who actually gets referred to and placed on an insulin pump. Looking at the same analysis then for those patients who received a PAK by insulin delivery system, you can see here during the 15 months roughly that the PAK recipients were managed from the time of evaluation to the time of transplant by an endocrinologist, there was no change whatsoever in their glycemic control, with a prompt improvement in glycemic control occurring postoperatively, with the initial post reading being 5.5% and 5.4% at 1 year. In the CGM group, there was minimal change in terms of glycemic control, despite use of a pump between the evaluation time and transplant. The A1C only decreased by 0.2. That difference is not statistically significant. A dramatic improvement in A1C between transplant and the post and 1 year mark. The A1C dropped to 5.4% at the 3 to 5 month mark and was 5.1% at the 1 year mark. And then in the self-monitoring group, there was actually slightly worse glycemic control despite being managed by endocrinologists for a mean of 14 months prior to transplant, with a dramatic improvement in glycemic control, as would be expected. From the date of transplant to the initial post-reading, the hemoglobin A1C dropped from 9.1% to 5.6%, and then remained 5.6% at the 1 year mark. And then looking at the A1C at the 1 year mark, there actually was a statistical difference between the glycemic control achieved in those patients who had been managed with an insulin pump pre-transplant and those patients who had been managed with self-monitoring. The A1C was 5.1% versus 5.6%. Now, obviously, the study as a retrospective single center study is subject to all the limitations that we know of for retrospective studies. There were no standardized criteria for who went on CGM and pump therapy pre-transplant. That decision was not made by our transplant center. That was made by their managing endocrinologists. And so there were probably some unmeasured differences between the 2 groups. That said, there was no difference in the pre-transplant glycemic control achieved in those 2 groups, despite there being any unmeasured differences. We also didn't have access to the CGM data and time in range and hypoglycemia, so we don't know exactly what those readings are and whether those patients were actually achieving any of the targets recommended by the ADA. That said, we know that a hemoglobin A1C represents a mean glucose level around 183, and the pre-transplant A1C values in our overall cohort were over 8%. So suggesting that they probably were not meeting the time and range goal targeted by the ADA. And then our study has a few patients with type 2 diabetes. Obviously, most studies have shown fairly similar outcomes between patients with type 2 diabetes and type 1 diabetes following pancreas transplant. And so we're no longer necessarily thinking about the type in terms of who's a candidate for transplant, but in terms of promoting our data to those outside the pancreas transplant community, that may be something that they would want to see. So in summary, following pancreas transplantation, we see a decrease in the hemoglobin A1C within the first year after transplant. That's fairly consistent across the type of pre-transplant insulin delivery modality between patients with type 1 and type 2 diabetes and by pancreas transplant type. And so, I think the title, the best insulin delivery is a human pancreas. I think that remains accurate. Pancreas transplantation provides superior glycemic control to CGM and insulin pump therapy, as well to self-monitoring multiple daily injection therapy for all types of pancreas transplant recipients, those with SPKs, those with PAKs, and those with PTAs. And I think this, we have the opportunity here. I think we as a pancreas transplant community need to do a lot of education and outreach to providers who are taking care of our patients with diabetes, to the community nephrologists and the nephrology fellowship programs that are referring a lot of patients for evaluation for kidney transplant and may not recognize which patients may be appropriate candidates for pancreas transplant and refer them for that as well. To dialysis centers as well, most of our patients with end-stage kidney disease have close relationships with the providers in their dialysis centers, probably much closer with their dialysis nurses and dialysis social workers than they often are with the nephrologist in the dialysis center. And then to community endocrinologists as well, this may not be as applicable to the SPK patients, but certainly in terms of referrals for PTAs and even PAKs, I think it's helpful for the community endocrinologist to have a sense of what the outcomes are with pancreas transplantation compared to what the current insulin therapies are providing. Thank you.
Okay, thank you very much for that presentation. I think one of the problems with everyone being on mute is you can't hear the roaring applause right now. I'm sure it's present. There's a lot of questions that have come through on the Q&A, and feel free to continue to add those. And please put them in the Q&A and not in the chat section if you're going to add questions, because I'm trying to manage both sites at one time. I recognize that, of course, you're presenting this to people who are familiar with pancreas transplantation. I think we're all aware of the fact that you get euglycemia when you have a pancreas. It would be nice if you were presenting this at the American Diabetes Association Journal Club. Some of the things that I think were noted as you were presenting that aren't necessarily on topic. I did notice that when you presented your demographics, it very clearly showed disparities in the pre-transplant care of patients. I don't think that needs further comment, but it is something that, when we are seeing patients, maybe we could be suggesting more that they go on pump therapies. And I got a lot of comments about the thymo dosing. So you're doing 1.5 per day for 7 days, is that correct?
Correct.
So I got 3 or 4 questions that were asking about BK, CMV, PTLD, length of stay. Do you do it outpatient? What is your rationale for using such a high dose of thymoglobulin? What is the outcome of that?
So we implemented that at the program's inception back in 2008. I think part of the rationale was to try to minimize the risk of rejection because of the real challenge with obtaining pancreas allograft biopsies, both at a center that didn't have a pancreas transplant program to begin with. And so without interventional radiologists who felt comfortable biopsying the allograft. And we still, 15 years on in our program, have a difficult time obtaining pancreas transplant biopsies in a timely fashion. We don't have fortunately, we don't have a very high acute rejection rate. Our rejection rates for SPK, PTA, and PAK are roughly around 10%. The SPK, the kidney rejection rate is around 13%. Our pancreas rate is much lower, but that's partly because we are often not biopsying the pancreas because we can use the kidney allograft as a sentinel marker for rejection within the pancreas. Our BK rate is around 25%, so it's slightly higher than what's been reported maybe with kidney transplant alone, but within the range of some single center studies within kidney and some other pancreas programs that have reported. We have only had one patient really with significant BK nephropathy. So with targeted immunosuppression reduction, we've been able to kind of avoid most of the complications related to BK nephropathy. We do face problems with CMV, but really only in our high-risk group. Our intermediate and low-risk patients have not had challenges with CMV infection. We just have started using a longer duration of valganciclovir for prophylaxis as a result. And with that, we've been able to see a slight reduction in our CMV rate. And we have not, knock on wood, we have not had any cases of early PTLD.
Okay. We got a couple of questions from Bob Strada. Should CKD patients with insulin requiring diabetes, I'll try that again. Should CKD patients with insulin requiring diabetes who do not have a living donor and meet consensus criteria be automatically referred to a transplant center that performs SPK transplants?
So I would say that you've read my mind. I really think that this should be an important quality indicator for patients with stage 4, stage 5 CKD or ESKD on dialysis who have diabetes with insulin. I think all of those patients we need to think of them coming in and being seen by centers that are going to advocate for pancreas transplantation and can make the best decision in terms of, is this patient a candidate for SPK? Is this patient a candidate for kidney transplant alone? What's the best management of their diabetes and kidney failure combined?
Okay. Another question from Bob Strada. Which is better metric? So you started off your introduction. I'm going to put some context here. You started off your introduction and your paper is entirely about HbA1c, but you spoke quite a bit about time in range. Which is a better metric to assess glycemic control? Is it HbA1c or time in range?
The endocrinologist may be better, served to address that. They're moving towards, for the CGM group, looking at time in range, as an important metric. But time in range, if you have a glucose that's 160 consistently across the entire day, your time in range is 100%, but that's going to correlate with a hemoglobin A1C that's high enough that you're going to see progression of diabetic microvascular and macrovascular complications. So I think looking at the two of them together, but I think the A1C is a very easy metric to look at, recognizing that there may be some challenges with using it in patients with advanced CKD. If you see that hemoglobin A1C down around 5%, you can estimate that their time in range is going to be pretty good, as shown with the CGM data from the Mayo Clinic that I had in the introduction.
Do you think, on the same note, do you think it'd be worth the Mayo program going back and basically replicating your study with the CGM data from before and after? Because you wouldn't have CGM data for after, but they happen to.
Right. Yeah. I mean, I think validating that, and if you can see exactly what the changes are from person to person with time in range, percent of time with hypoglycemia, and see the real benefit of the pancreas transplant. Even if you're seeing it within the first month when patients still have the lingering effect from either high doses of steroids or on higher doses of steroid during the prednisone taper, you can imagine what you might see if you were to recheck the CGM data at 9 or 12 months when that A1C is at 5%, how much, what percentage of time in range would be and how little hypoglycemia we'd actually see.
Okay. Last one from Bob. Is there any evidence to suggest that diabetes management following kidney transplant alone is more difficult than prior to transplant, which might be used as a rationale to promote SPK or BAK?
I haven't seen anything specifically. There may be something out there that I'm not aware of. A lot of these patients, though, are challenging to manage post-transplant. We know that insulin requirements often increase, probably more so for patients with type 2 diabetes than for those with type 1 diabetes. But you have challenges, especially early on, related to liberalization of diet after they're no longer on dialysis or have advanced CKD. Challenges related to potential glycemic effects of some of the transplant medications. And certainly we've all probably seen patients who despite being managed in transplant centers with access to endocrinologists, wind up developing recurrent diabetic nephropathy, and they're living donor allograft within a few years after receiving a live donor transplant.
Okay. I'm seeing that I lied and Bob has more questions further down. Assuming you have presented this data to your own institution and local endocrinologists, what was their reaction to this?
So we have not had the chance to present this to our endocrinologists. I've reached out to try to see if we can kind of, speak with them and work on education on pancreas transplantation, especially I think for the endocrinology fellows who wind up going out into the community, because I think having had a couple of patients with kind of pancreas allografts that may not be totally functional get referred back to endocrinology, I think there's a real lack of knowledge about pancreas transplantation among community endocrinologists, including those who trained at programs that have pancreas transplant programs in their hospital. And so I think we really do need to work on outreach to both the academic medical centers and community endocrinologists to educate them about the outcomes of pancreas transplant.
Okay. Ron Parsons asks, any caveats for longer term results, 3 to 5 years at your center?
We did not look at longer term results for this study, but we have, for most of our patients, seen kind of glycemic control remain in the low to mid 5 range as defined by hemoglobin A1C over the long term. But looking at, getting more data, especially CGM data in patients over the long term to see if there's any changes with time in range or changes in time with hypoglycemia as you get farther away from the time of transplant, I think would be a useful study as well.
Okay, next question again from Bob. For CKD patients with uncontrolled diabetes prior to transplant, with hemoglobin A1Cs of like greater to 10 to 12%, should that be an exclusion for either kidney or SPK as a measure of compliance?
We haven't used that as an exclusion. We've had several patients who come in with A1Cs that are, 9, 10, and certainly if they're getting an SPK, you suddenly see, dramatic improvement in glycemic control after the transplant. We haven't necessarily used that as an exclusion criteria among our patients who are looking at kidney transplant alone, although oftentimes those patients who have A1Cs in the 10, 12, 14% range have other complications that may make them higher risk and cause us to press pause in the transplant evaluation until those factors get sorted out.
And Bob, the other thing is that there's 2 individuals involved in achieving that hemoglobin A1C. There's the person who's taking the medication. There's also the person who is prescribing and adjusting the medication. And I don't think everybody has the same skill set. And again, there's also disparity issues there. Yolanda Becker says that this was an excellent presentation and would like to know if you can comment on how you have grown your own referral base. I'm paraphrasing.
Okay. Well, we are working on trying to grow that referral base. It's kind of been a slow process with outreach to community nephrologists, and our program has grown a little bit, but perhaps not as much as we'd like it to. And one of the challenges in New York City, of course, is that there are multiple competing centers with pancreas transplant programs, which can make it a little more challenging to get our volume up. But we do try to, at the very least, everyone who comes in with diabetes on insulin, we try to ask the question, why is this patient not a candidate for pancreas transplant? Whether they're initially evaluated by someone in our pancreas transplant program or whether they're kind of triage to the kidney transplant pathway, we review all of the evaluations, and we are probably able to convert 1 or 2 patients a month from the kidney transplant alone pathway to the pancreas transplant pathway.
Okay. Mariella Artigosa Goggins says, thank you for a nice study. Congratulations. And she wants to know if any of your patients required oral hypoglycemic agents post-transplant, how many remained or need to restart steroids?
So in this cohort, I believe there was 1 patient who was on metformin. No one else was on any oral or injectable diabetes medications through the first year. Sorry, what was the second half of the question? Steroids. So, we generally speaking, we do not restart steroids in the absence of rejection. For those patients who are treated with steroids for rejection, we don't retaper off steroids, so they're maintained on steroids. I don't know the percentage in this study who wound up on maintenance steroids at the end of the first year, but as I said, our 1-year acute rejection rate is 13% for the SPK patients and about 10% for the PAK and PTAs. So assume approximately about 10 to 13% of the patients may have been on steroids by the end of the first year in this cohort.
Okay. Dr. Balamarugan Apakale asked, excluding immune rejection, what are the possible reasons for declining islet function over a period of time after pancreas transplant?
I guess, chronic rejection, I guess there are rarely reported cases of recurrent type 1 diabetes. We have not seen any cases there at our center. I know that they have been reported from other centers. We've seen, you can see decline, I guess, related to other chronic infections. But I think, chronic immunologic failure tends to be one of the main reasons why we see kind of declining islet function over time.
Vasanthi Balaraman asked if the wait time for SPK and kidney alone was the same, would you still consider all patients to preferably get an SPK? Presumably by all patients, they mean all candidates that are suitable for.
That's a great question. I think the longer term data, are suggests that there's, there may be some increasing survival benefit with longer duration of, euglycemia following SPK. And so some of that may depend to a certain extent on how reasonable we think the patient's living donor will be in terms of working out and what the age is. And then discussing with the patient, a lot of patients, when they're faced with that decision, decide they really want the pancreas transplant, but don't want 2 surgeries, and so opt for the SPK. We've had other patients who will opt for the living donor kidney. It's their family member or a friend who wants to donate to them. They want to get off of dialysis ASAP and not really wait for the potential uncertainty of an SPK. And then they'll consider PAK after they receive their live donor kidney.
Okay. I think that there's a lot of good evidence that being free from dialysis and being independent of insulin with normal sugars has a patient survival impact. I don't think it's immediately, but in the long term, SPK patients perform better than living donor kidney transplant patients alone. So I know our program, if somebody's a candidate, we offer them both organs in some form, not necessarily SPK versus PAK, but yes, we certainly would offer them a pancreas. It's not a matter of the timing. Is the question they're asking that whether or not they'd be offered an SPK or whether they'd be offered a living donor and a PAK? I think it's whether they'd be offered a kidney or an SPK. Okay. Bob is asking to please ask the above question. Bob, if you can send another message telling me what you mean by that, we'll gladly do it. How much time do the patients, how much time do you take off from a patient when doing SPK versus kidney alone? 2 years? I think what they're asking, that's Fernando Moran. I think what they're asking is how much shorter is the wait?
So, recently in our region for patients who are blood group O, the waiting time is approximately 2 years for an SPK and kind of 1 year or less for the other blood types. Which is, going for blood group O is probably taking off 2+ years from the waiting time. And for the other, for blood group B, especially, it's taking off 5 or more years from the wait time. So, in addition to all of the benefits provided by the pancreas with the SPK, what we're seeing, significant improved access to transplantation in general for patients who are getting the SPK versus staying on the waiting list for kidney transplant alone, just getting off of dialysis much more quickly. And as Dr. Fridell pointed out, not being uremic and not being hyperglycemic is very good for the body over the long term.
Okay. In the last moments, I see we still have a couple of other questions, but I wanted to get to this one. This is from CIDR. This is islet transplant outcomes, showing the percent of hemoglobin A1C less than 7%. There's two different graphics basically showing the same thing. Taking in this information, can you put this in the context of what we're achieving with pancreas transplant?
So, looking at the 1 year mark here, the A1C that is being achieved in the islet transplant alone and the islet after kidney group, it looks like the mean is somewhere in the low 6% range at 1 year. Although I know that, at that point, I believe roughly 50% or so of the patients are actually back on insulin or insulin dependent. So some of that glycemic control is being achieved despite needing insulin or potentially other diabetes therapies. And I guess it looks like the mean kind of increases slowly over time by 5 years, where I know the rate of insulin independence at that point drops to about 30%. So it's certainly, I think, better than the data I showed from the IDCL study looking at closed loop systems and pumps, but not quite as good as what we're seeing with whole organ pancreas transplant. At least within the nephrology literature, there's some evidence to suggest that pre-diabetes may be associated with an increase in certain health issues, including progression of albuminuria, new onset of chronic kidney disease, and there's even some literature suggesting potentially increased risk of atherosclerotic vascular disease and heart failure. And so that hemoglobin A1C change, of if low 5% with a pancreas transplant compared to a mean of 6.3 to 6.5, which is technically at target below 7% and would be considered successful, there may still be some health abnormalities, some comorbidities that develop as a result of that increased A1C compared to what we're seeing with pancreas transplant.
Okay. And I think, I'm sorry if we didn't get to your questions, but I think that's where we probably have to wrap up because it's 3:01. So I'd like very much to thank Dr. Dube for his presentation. I know Casey McCune is online, so thank you very much. This was a wonderful paper. And Dr. Ratner, who's, I guess, still in surgery, tell him this went well. Thank you, everybody.
Thank you.
AST would like to thank Dr. Dube and Dr. Fridell, the leaders of KPCOP, and all of our attendees for today's session. For those questions we did not have time for, we will either answer them individually offline or post the full question with the answer on the website following the Journal Club. Please remember to complete the evaluation survey in Zoom and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's KPCOP, please visit myast.org/COPS or connect directly to the individual KPCOP hub. Thank you all again for today's great session.